I think we say, am I audible, right? We can initiate discussion. So first, let us. I will invite very basic questions. Those who have got some doubt in very basic things, which are related to infertility practice. Please unmute yourself whenever you want to ask anything. Am I audible?
Yes, sir.
Please answer. Am I
Good
audible?
morning. Yes, yes.
Okay. Yes. Which topic you want me to discuss? Because this is open discussion. So you have to tell me which topic you want me to discuss.
Low dose HCG protocol.
Okay, first we'll take low dose SCG protocol. Hmm. So the LH receptor, presence of LH receptor, there is a changed concept. Earlier we used to think that LH receptors are not present in small antral follicle or pre-antral follicle, and LH receptors develops on granular cells once the follicle reaches 8 to 9 millimeter, and following which the estrogen biosynthesis starts in a significant fashion. That was an old understanding. Now, as per the new understanding, LH receptors are present even in the pre-antral follicle and early antral follicle. The quantum of receptor is less as compared to the follicular size, which is of mid follicular, that is 8-9 millimeter. That does not mean that the LH activity is useless in early follicular phase. Once LH receptors are there, that itself suggests that there is some role of LH activity. The same concept is there for the endometrium. The LH receptor, LSCG receptors are present in the endometrium, especially in the luteal phase, secretory phase. That itself speaks about the utility of the LH activity even in the embryo transfer, endometrial receptivity. So LH undoubtedly plays a very important role. We should not think in the direction that if LH activity is absent, the follicle cannot be developed. Even without LH activity, the follicle mitotic activity is going to happen and follicle is going to develop. But the estrogen synthesis is going to remain hampered, and estrogen is very, very important for fine molecular events which are happening at the oocyte and OCC complex. So estrogen plays very important role. So suppose estrogen is not there, one the health of the oocyte is disturbed, and second, it hampers the proliferation of the endometrium. It hampers the development of the progesterone receptor on the endometrium, and so by that it hampers the uterine, endometrial receptivity and transfer result. So it is not a good idea to uh, stimulate even when the LH level is very, very, very low. So what cutoff we believe in LH level when we say the LH activity is sufficient? The fortunately for estrogen biosynthesis, even if the 1% of the receptor, 1 to 2 receptor, 1% of the receptors are occupied on the granular cells, the estrogen biosynthesis is not hampered. So furthermore, LH activity is not required. That's a good thing. So when we want to measure serum LH level at the beginning of the cycle, that guides us in a two-way. One, the estrogen biosynthesis is going to be adequate or not. And two, if you give agonist trigger, the agonist trigger is going to work or there are chances of empty follicle syndrome. What are the chances of empty follicle syndrome? So these two information we get when we measure early follicular LH level. And third information, if the early follicular LH level is very high, which typically happens in PCOS, you anticipate that the stimulation is going to be difficult. You anticipate that stimulation, the gonadotropin dose requirement is going to be quite high and stimulation days are going to be longer. So if you want to cut short this and if you want to make this more friendly, either you have to increase the dose at the beginning of the stimulation or better will be you bring down the LH by giving antagonist. So give antagonist, LH level will come down. So at least you will take less time to attain the ideal FSH LH ratio. So lesser dose of FSH will be required. So this is about the LH levels at the beginning. Now there is one study which has said that LH activity or in fact they have measured SCG level. Studying recombinant LH addition versus SCG addition in during the stimulation, and they found out that mid follicular level of SCG directly correlates with a better follicular outcome and better fertilization and better implantation. So SCG at mid follicular phase and later on plays a very, very important role. There is another study which says that as compared to the recombinant LH, if you want to add LH activity, the SCG is superior to recombinant LH when patient is advanced age, more than 35 years. So in that, the SCG scores above the recombinant LH. In rest of the all condition where LH activity is required, the recombinant LH is better compared to recombinant or the SCG. But we all know the recombinant LH is quite costly and it is very easy to prepare a small dose of SCG and administer a small dose of SCG, which is quite economical and rewarding. And we can do a lot of wonder by using a small dose of SCG. So we started using a small dose of SCG whenever we felt that LH activity is required. So, which are the places? First of all, how small dose of SCG to be prepared. So, either you can use recombinant SCG or you can use urinary SCG. As you know, the recombinant SCG is 2050 microgram in uh, zero point 0.6 ml. So that comes to 6,500 unit of SCG activity in that zero point 0.6 ml. 250 microgram is equivalent to 6,500 unit of SCG. So either you can use recombinant SCG or you can use urinary SCG. The advantages of using recombinant SCG is you don't require to be reconstituted from the lyophilized form. So it's ready-made liquid solution. The only problem is you have to finely titrate the dose. That is a difficult job. That is one thing. And second thing, uh, whenever you want to utilize the full potency of pre-filled syringe, always prefer uh, manufacturing date should not be uh, more than 6 months ago of your use. So I never use a liquid status gonadotropin or any other injection which are manufactured later, I mean before 6 months, more than 6 months back. So it is always preferable to use fresh batch. Keep buying in a small quantity and that will give the best result because the potency of any liquid preparation starts deteriorating after 6 to 8 months. So that's the idea why it should be used in a fresh manner. On another side, if you are using a lyophilized form of SCG, so which is not in recombinant SCG, but which is available in urinary SCG. The urinary SCG is available in liquid status also, and which is available in lyophilized form also. Lyophilized form is always stable. Uh, what I mean to say, stable means if there is a little temperature fluctuation, if the the manufacturing date is longer than 6 months before, then also the stability of the lyophilized form doesn't go. So that way it is a stable. But the problem with the lyophilized form, once you dilute, when it comes in contact with the air, it quickly deteriorates its potency. So there is no clear-cut data from the company manufacturer that after reconstitution it can be used for how many days. No company will give the data. They will say it has to be consumed immediately. There is a paper by Abulgar who advocated uh, using low dose SCG uh, uh, long back, and he has written in his article that if you dilute with the normal saline, the urinary SCG, this reconstituted solution retains the potency for 3 to 4 days. But there is no scientific support behind his statement. So I am little skeptical of using reconstituted solution for 3, 4, 5 days. So earlier I used to use urinary SCG diluted because which was turning to be quite economical. I used to keep 2000 unit of SCG, reconstitute and keep for 3 to 4 days and use in this one patient and then throw away. But the results were not as per the expectation. So I switch over to uh, either recombinant SCG or utilize whatever urinary SCGs I reconstituted in the same day only. So if multiple patients are there, I can use all of them. This reconstituted solution of SCG and just throw away within 3 hours, 3 to 4 hours, balance solution, and next day make new. So either you can do that or you can use recombinant SCG. So whatever SCG you use, always try to use 100 unit of insulin syringe. That will make your life much easier. And that is one thing. And second thing, suppose you are using a SCG, uh, urinary SCG, then it is to be diluted with the normal saline because here diluent is normal saline. Suppose if you want to further dilute for using for multiple days, then you may dilute further with the normal saline. But again, because of the change osmolarity, the potency of the molecule may get disturbed, and no company people are ready to guide what is going to happen if we dilute further. So I have stopped diluting further. If you are using recombinant SCG and still you want to take risk and you want to dilute further to use for many patients or multiple patients or many times, then you and if you decided to dilute, it should be diluted with the distilled water for injection. Because there in recombinant SCG, the diluent is water for injection. But I recommend not to dilute further than the prescribed dilution volume. Instead of that, use 100 unit of insulin syringe and give a very, very minute, minuscule dose, 1 to 2 units of SCG that you can manage still rather than, and that is which is more scientific. So this was about the using how to prepare the recombinant SCG and urinary SCG. And further is a just mathematics. Suppose you are using 100 units of insulin syringe and you are using RSCG, so 1 unit is equivalent to 65 unit of SCG. So if you want to give 150, little more than 2 units are required to be administered. Similarly, suppose if you are using urinary SCG 2000 unit, then 1 unit of and if you dilute in 1 ml, then 1 unit of your insulin syringe is equivalent to 20 units of SCG. Sorry, 200 unit of SCG. Yes, 200 units. No, 100 units. No. Okay, 20 units of SCG. So if you want to give 150, you have to give 7, 8 units of urinary SCG from that insulin syringe. So this is just simple mathematics. So this was regarding how to prepare the SCG. Now, I have inquired a couple of injection syringe manufacturers, and I requested to make insulin syringe which can calibrate 200 units of the solution. So now they are saying that for that they have to make a new die, reduce the internal diameter, and the redesign. So just I'm in conversation with them. So if that becomes possible, then our life will become quite easy because we will get the insulin syringe, which in 1 ml there will be marking of 200 units, which will, of course, the syringe will be little larger size, internal diameter will be less, but still it will become to administer a small dose will become more easier. Okay, now coming to which are the places where a small dose of SCG is useful. To start from the pre-treatment, that means before in the luteal phase, before starting the stimulation, there is a role of SCG. So especially in poor responder, especially young poor responder, Poseidon group 3, where the oocyte has got some maturational defect. And that is the reason, in spite of they being young, their AMH level, in spite of the AMH level, uh, their AMH level is less, and enteral follicle count. Uh, sorry, I'm sorry. The AMH level, this is Poseidon group 3. In spite of young age, they are responding in a poor fashion. So they have some maturational defect, and these defect gets amplified when they are exposed to FSH before they are exposed to LH. So in such patient, if they are exposed to small LH activity, this maturational defect is getting corrected, and following which, if they are simulated with the FSH, uh, the outcome, the oocyte quality is better in a qualitative fashion, if not quantitative fashion. So this is a one area where you can use small dose of SCG. The another uses of small dose of SCG is continuous administration of the small dose of SCG with the idea of androgenization of the follicle, reducing the apoptosis, and uh, by that change in the AMH level, change in the maybe some AFC level. This is in very, very diminished ovarian reserve. So this is another area where different care protocol and another one protocol is there. I forgot the name. Endro protocol, where they use a different dose of SCG. So SCG can be used in this fashion also. So this is about the before uh, initiation of the stimulation. Now, when we initiate the stimulation in Poseidon group 1, 2, and 4, there is definite need of LH activity during stimulation. So, forget Poseidon group 1 because that we come to know after stimulation only. Let us talk about the Poseidon 2 and 4 who are elderly patient. And in Poseidon 1 and 2, they have got adequate ovarian reserve, and Poseidon 4, they have got diminished ovarian reserve. So elderly, diminished ovarian reserve, elderly, good ovarian reserve. So in this patient, LH activity is must. Now, if you want to use LH activity right from the beginning, you may argue that we can use HMG. Why such? Why to create some problem? Why not to use HMG only? You can do that, but HMG actually contains very limited true LH activity. So when there is a deficiency of LH activity or you want to supplement the LH activity, HMG is not very good idea. Not very good idea. You have to supplement with the small dose of SCG. All HMG injection, highly purified injection, to provide a 75 international unit of LH activity, they use 9 unit of SCG, which surrogates the LH activity. But this activity is not sufficient. So you, when LH activity you want to add, you need to add something more than this. So LH externally supplemented is required. So small dose of SCG, 125 to 150 unit of SCG, you can administrate along with RFSH or HMG right from the beginning of the cycle. Now, what hormonal level are going to be when you administer a small dose of SCG during your stimulation? You will be worried that okay, luteinization, premature luteinization may happen. These can happen. It can initiate LSH, then it can cause ovulation. No, nothing happens. If you restrict your dosage up to maximum 200 units, ideally 150 unit, not to exceed 150 unit. Your serum SCG level during follicular stimulation remains less than 8 to 9. It never crosses 8 international unit. So, which is quite safe not to cause a luteinization or initiate the ovulation. So, this is about the SCG level. Now, once you start adding small dose of SCG right from the beginning of the cycle, by the time you reach a mid follicular phase, your SCG level is significant. And as it has been proved by the study that the cycle outcome is directly proportionate to day 6, day 7 SCG level. So you're going to get good result, which is proven by the study. So this is about the providing a small dose of SCG right from the beginning of the stimulation. Now, the third way how small dose of SCG can be beneficial. So whether you are stimulating with the oral drug or with the gonadotropin, maybe time intercourse cycle, maybe IUI cycle, maybe IVF cycle. Once the follicle reaches 9 to 10 millimeter, they acquire, they have got adequate LH receptor. And furthermore, stimulation can be handled maybe more with more ease by LH rather than FSH. So LH is capable enough to carry forward the stimulation of the follicle further because of the very good number of the LH receptors. So in such scenario, to cut the cost, to save the cost, you can start a small dose of SCG instead of gonadotropin, and which will substantially reduce the cost of the cycle, and patient will be benefited by getting LH activity. Now, what is the advantage of another advantage of providing LH activity uh, regarding the progesterone elevation? So, if you add LH activity right from the beginning, there will not be any backlog of progesterone because the LH effect of LH on LH activity on whether it increases the progesterone, circulating progesterone, or it reduces the circulating progesterone is depending on which pathway is dominant. There are two pathways. So we do not, that is a very minute endocrinological discussion. We will separately discuss that. But for your understanding, if you use a small dose of SCG right from the beginning, the progesterone load is not there and it is clearing regularly, and so there is no progesterone elevation noticed. But if you use SCG in the later of the cycle, in few of the cases, you find progesterone to be elevated and which can hamper your receptivity. So it is better to start use SCG right from the beginning, and your progesterone level is normal on the trigger day, the endometrial is good, and you intend to transfer fresh, then that small dose of SCG to be continued in luteal phase also, which can potentially allow you the progesterone free luteal phase. Suppose you have continued a small dose of SCG even in luteal phase, you may not start a progesterone because that is taken care by the progesterone which is secreted from the corpus luteum following the trigger and later on the supplementation of the small dose of SCG. So this is about the follicular supplementation of the SCG. Now coming to a luteal supplementation of the SCG. As couple of minutes back only I said, virtually uh, it is possible to have the progesterone free a luteal phase if that activity is supplemented by the small dose of SCG. Now, a very important fact I would like to draw your attention that even if you are using agonist trigger and suddenly think that okay, this patient you were expecting OHSS, but the OHSS has not occurred, and you want to transfer fresh. So if you are changing your decision to transfer fresh, then you are given agonist trigger. So it will cause a rapid luteolysis. But the SCG has capability to reverse this luteolytic activity of the agonist. If you provide a 2000 unit of SCG within 3 days of your agonist trigger, the luteolytic activity is halted and corpus luteum will become again active and start secreting progesterone, and you can go ahead with your transfer. Suppose you have forgotten and you have not started the SCG within 72 hours of your agonist trigger, still you get a chance. If you give a little higher dose up to 5000, even after 6 days of your initial agonist trigger, still the corpus luteum is rescued, it starts secreting progesterone, and you can go ahead with the transfer. So that's the potency of the SCG molecule, which acts on the corpus luteum in a very, very efficient way. The another way is still if you want to keep corpus luteum active, you want to supplement something. Suppose you have given SCG trigger, for example, and still you want to go ahead with the transfer, fresh transfer. The problem with the SCG trigger is the early rise of progesterone is very, very high. The progesterone within 48 hours is at the peak and after trigger, and it starts declining 4 to 5 days, 5 days after the trigger. Fifth day of trigger, it starts declining, and by 8 day post trigger, the progesterone level is lesser than what you get in your natural cycle, and this is quite alarming. So this is progesterone deficient period is the actual period for implantation of the embryo, and where the implant during the progesterone is needed most when implantation is happening for immunomodulation to calm down the uterus, preventing the expulsion of the uterus, anti-inflammatory effects, and whatnot. So if the embryo is getting close to the endometrium, and when the environment is progesterone deficient, it definitely hampers the implantation. So even when you have given SCG trigger and you want to transfer the embryos fresh, it is a good idea to supplement with a small dose of SCG, maybe 2000, on fifth or sixth day of your SCG trigger, and you can go ahead with the transfer, and then you will have a very good luteal level of progesterone. So this is another way of using small dose of SCG. Uh, I think I have included almost everything related to small dose of SCG. So if any question, you are most welcome regarding SCG, small dose of SCG.
Good morning, sir.
Good morning.
Sir, I wanted to ask this 9 units of HCG you mentioned previously. What was that?
So now Bharat Serum has got UMOG HMG,
Yes, sir.
which is not purified. It has got HP HMG also, UMOG, and simple UMOG also. Now this simple UMOG has got natural LH activity. That LH activity is natural, but it comes with some protein impurities and which can create some maybe some small anaphylactic reaction or maybe small reaction at the local site of injection. So normally we prefer HP HMG, highly purified HMG. During the purification process of the urine purification process of urine, this LH activity gets distracted. So all the company, while preparing, manufacturing highly purified HMG, they add small dose of SCG to provide the LH desired LH activity. Now in 9 units of SCG provides a 75 international unit of LH activity. So in other word, when you are buying a 75 unit of HMG, it contains 75 unit of FSH activity and 75 units of LH activity, which is derived from 9 unit of SCG. Now got it?
Okay, sir. Thank you. Thank you so much. So that means, sir, this 9 units is not practically, we don't have to remember. It's just that 75 has got 9 units of HCG.
Yes.
So, sir, like you had taught us small dose E2 luteal phase E2 antagonist protocol. So if we give it for poor responders, after we start stimulation on day 2, again we supplement with small dose of HCG in that poor
So
responder.
it is a better idea in positron group 3 or any poor responder, elderly
Okay.
especially. Suppose you, because in polder, what happens in why I like this protocol very much, because it takes care of asymmetry, it takes
Yes,
care
sir.
of symmetrical follicular cord, it takes care of uh, LH activity, it takes care of the pre-stimulation LH activity, it takes care of the, because in poor responder you have tendency to transfer fresh as per the
Yes.
recent understanding, recent evidences. It is if you are getting less than 10 oocytes and if your progesterone level on the day of trigger and 12 hours post trigger is within the normal range, endometrium is good, you must transfer fresh. So if you your intention again is to transfer fresh in poor responder. So right from the beginning, if you start adding LH activity and that you continue even after the pickup, that provides a very good environment for embryo to implant.
Okay, sir. So it will be right from the
Luteal,
pre-stimulation phase,
luteal, till till
day
till
21.
till
Yes, sir.
transfer.
And also, sir, after the OPU, again you have.
It should continue
Um,
same
okay, so it
at
will
least for
take.
10 days. 10 days.
So then we will be giving progesterone also, sir, after OPU.
Progesterone, progesterone theoretically you may not give, but practically
Yes.
dydrogesterone you can add.
Okay, so maybe we don't need the vaginal progesterone, sir.
Yeah,
Okay, okay. Thank you so much. So, sir, most of our patients are Poseidon group 3 or 4. So we can give this protocol which you have taught today, na?
absolutely.
Thank you so much, sir.
Hello, sir.
Yes,
Hello. Can I ask you one question?
why not?
Sir, how much personal experience you have with this protocol? What is your personal experience? You are telling your personal or from datas?
No, I am not in position to provide a concrete evidence from my personal experience
No,
because
just we want to share with you ki practically because we read so many things
hmm,
on Google and all these things. But when we are, I mean, doing some practical work, then we are afraid to start the new thing because we are getting
I can tell
results
you,
with the old protocol, start new
yeah, yeah.
protocol. So that's why we want to share. This is just privately because if you think
No,
you
no,
are confident, then we can
no,
start.
no.
Otherwise,
Listen,
we'll
listen,
think
listen,
twice.
listen, listen.
Yeah.
Yeah, listen. So whatever protocol I suggest, which I tried in my practice. it's not absolutely I'm going theoretical. But if you
Okay.
say, if I would tell you the exact whether it is making significant difference in the results or not, I'm not in position to tell you. I can just tell you it's my impression. It is making difference.
It's
You
making
got it?
difference.
Because I am
Yeah.
not a researcher, no? And I
No,
don't
no, no,
intend to become researcher. I don't
no,
have
no.
that much time to become researcher. But whatever evidence based medicine is there, evidence are there, we can always incorporate in our practice if that matches our logics, that matches our endocrinological knowledge. Those people who are who are not ready to change themselves, they keep arguing about uh, what is your data, what is your without any have you published any study or not. So that's one should not get discouraged by such questions, and that's the reason I can assure you that whatever protocol I suggest, it has been tried by me and found no adverse effect. It may be little more useful than your conventional protocol, if not uh, lesser. It is either same or it is better than what protocol you are following.
Okay.
Hello, sir. Have
Thank
you
you, sir.
ever tried a low dose HCG in an IUI cycle?
No, low dose SCG in matlab you mean to say follicular phase?
Yes.
Follicular phase many times. When there is a constraint, economical constraint
Huh.
for the patient,
Huh.
then definitely I have tried couple of times.
Okay, so that also in
So
Poseidon
sometime
group 3 and
sometime sometime what happens? There are a lot of things which we want to incorporate. Suppose after attending this lecture, 10 people must be thinking, okay, we will incorporate in our practice. But
yes.
when patient comes, they forget. They tend to do
Yes.
whatever things they keep doing.
Yes.
And the
Yes.
same thing, because I am reading hundreds of articles. And while reading the articles, I think that I should incorporate this in my practice. But
Yes.
many times I forget. So what
Yes.
now I have done on my case paper only, I have written all the strategies or all the molecule which I want to incorporate when need arises. So I go through those molecules and then I get idea. Oh yes, yes, this can be done. Yes, this can be
Mm.
done. So
Mm.
then I incorporate that in my practice. This is how it goes.
So, sir, IUI cycle in an IUI cycle, where have you used it? Like how did you decide on using it, and where exactly did you use it in an
Okay,
IUI cycle?
I will tell you typically. So what happens? Suppose you have given letrozole, for
Mm.
example. Hmm?
Mm.
And after giving letrozole, after 5 days of letrozole, you
Mm.
call the patient on
Mm.
cycle day 8 for
8.
example,
Huh.
and the follicles are typically say 9 millimeter.
Mm.
Then again you call after 3 days,
Mm.
and if you observe the follicles are still stagnant, maybe 10 millimeter or 11 millimeter, it is not
Yes.
growing as per the expectation. So you would
Yes.
like to boost up this follicle with some gonadotropin. Now, if the
Yes.
patient is not affording,
Huh.
uh, I would start directly a small dose of SCG,
Okay.
and definitely follicle will develop. That's one way.
Oh.
Second, you can use gonadotropin, which will give you more stable or confident result, because you have
Mm.
not tried SCG. Na? If you are
Mm.
using SCG for the first time, definitely you will have little hesitation as compared to the SMG.
Yes.
But
Yes.
that
Right.
hesitation will go away once you start using. And third way,
Okay.
you can continue extended letrozole protocol.
Mm.
I am not, I right from the beginning, I am telling you, I am not a very fond of or strong believer of very extended letrozole protocol.
Mm.
You
Mm.
might be getting good result. I do
Mm.
not have objection for that. But
Mm.
I never like to give letrozole more than 7 days.
So, sir, if we have given letrozole for 5 days, then we observe that the follicle is not growing. Can we restart letrozole in spite of stopping it in
So
between?
now I have changed the strategy. I give letrozole for 7 days, not for 5 days.
Okay. Okay.
And 95%, more than 95%, 7 days letrozoles are sufficient. By the time I
Okay.
call the patient after finishing the course of letrozole,
Huh.
The follicles are always more than 12 millimeter, 13 millimeter,
And letrozole is 2.5 or 5 milligrams, sir?
5 milligram,
5
Depending on
milligrams 7 days.
2 HS, 2.5
2H.
milligram, 2 tablet, 2 HS for 7 days.
this
But
is
okay.
excellent idea. Excellent idea.
Yes, yes,
Yeah.
yes. This is a very
Does
good
it
Now
thing.
have
I will give one more better idea than this. What
Hmm.
I do, I give clomiphene 25 milligram,
Okay.
and that is to be started from the last 2 days of letrozole. So suppose letrozole has been started from cycle day 3. So 3,
Hmm.
4, 5, 6, and 7. Okay. So cycle
Okay.
day 7, they will start a clomiphene 25 milligram.
Oh,
Okay. So what is
okay.
the purpose? What is the purpose? The purpose is uh, I want to have still some effect which on the pituitary
Hmm.
which can make pituitary pushing continue pushing more FSH,
Hmm.
natural FSH. That's one idea.
Okay.
Second
Okay.
idea, I want some LH activity. So if I give clomiphene, the LH activity or LH secretion is better as compared to the letrozole from the pituitary. That's the
Okay.
second idea. And third
Okay.
idea, I am able to prevent a premature LH surge when I am supplementing the cycle with the 25 milligram of the clomiphene. That will bind the pituitary, bind with the pituitary E2 receptor, and the pituitary will become blind to the rising level of estradiol, and that will prevent the LH surge to happen. And we all know in time intercourse cycle and IUI cycle, in 20% of the cycle, the LH surge happens, and that's the reason our cycle goes haywire. So
Yes.
I want to prevent LH surge. So that's the most economical way of dealing with the time intercourse and IUI cycle.
And CC only for 2 days, sir?
No, 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 2 days. It is to be continued till trigger.
Acha, CC continue till trigger 25 milligram.
Yes.
Okay.
So
Okay. Very nice.
this protocol is never ever mentioned anywhere. Now,
Yes.
please, please don't ask me to provide evidence for that. It's my protocol.
Yes,
yes, sir.
yes.
So,
Yes, sir.
Sir,
This is a very good
letrozole,
idea.
yes,
hello.
sir.
Very nice.
Yes,
Very
yes.
nice.
Sir, good morning, sir.
I got
Good
letrozole
morning.
2.5, sir.
Sir, I have one doubt.
Please,
You
one at a
said,
time. Please, one at a time. I cannot answer. Please, one at a time.
sir, good morning, sir.
Dr. Supriya is speaking. Right. Okay.
Uh, Sir, good morning. Sir,
Good
you
morning.
said we have to start letrozole from day 3, right? And
Hmm.
clomiphene from, you say, after starting the letrozole on day 3, we have to start 25 mg cc. Now,
Seventh day.
when
Seventh day.
day 7th, okay, fine. Day 7th. So when you start this, so LH, if it is very high, then it is not detrimental to the OA for IUI cycle also?
Up to see in donor cycle we are regularly using clomiphene 50.
Sir,
Clomiphene
cannot hear
7.
your voice. Hello.
Hello.
I,
Am I audible?
I can't hear your voice, sir.
Yes, sir. You are very much audible.
No, no, there is problem. Some problem at your end.
Audible, audible, sir. You're audible.
Okay.
Okay.
Yes, sir.
Yes,
So
sir. Yes.
25 milligram, 50 even up to 50 milligram of clomiphene, um, the LH level is not that high to cause any harm on the oocyte.
Okay.
Okay. So, this letrozole, they say that if you give 5 milligram, maybe.
Please
Uh,
don't ask chain of questions because then other people will not get idea. I mean, chance to ask.
no,
So
sir.
please ask at a time two
This
questions
I was
only.
asking. No, no, sir.
Yeah, please.
This very protocol I'm asking, sir.
Yes.
So I was
Sorry.
asking this 5 milligram. Sometimes in your classes you had said that 2.5 is better because it does not have a
Yes.
bad effect on endometrium.
Yes,
That's
you are
why.
right. You are absolutely right. You are absolutely right. If you are ready, because I do not want to extend the protocol. If you are ready to extend the protocol, or if you want ready to add HMG in your stimulation cycle, or if
Okay.
you are using letrozole for endometrial preparation, Still, my preference is 2.5 milligram.
Okay, sir.
Now here, I do not want to miss. I want to make the cycle in time, and same time, suppose suppose follicle has developed following the letrozole, and endometrium is still lagging behind.
Mm.
I already started a clomiphene,
Mm.
which will allow me to pull the cycle till the endometrial thickness is achieved. You got it? Because LS surge is not going to happen mostly.
Sir, okay, sir.
Okay?
So clomiphene,
But
sir, will again not be bad for the endometrium?
no, clomiphene is not that bad as it is thought, especially uh, when it is used in the later half of the cycle.
Okay, yes, sir. Yes, sir.
See,
This you had to.
I tell you, the clomiphene, probably I don't know, I have said many times before also, in unexplained infertility,
Yes.
the clomiphene cycle where you have used gonadotropin before clomiphene or after clomiphene.
Uh,
The
gonadotropin.
cycle
Yes.
before gonadotropin or after gonadotropin. And second, if it is a unexplained infertility, the thin endometrium which is forming after clomiphene does not affect the cycle outcome.
Okay.
So,
Okay.
clomiphene, letrozole is definitely better as compared to the clomiphene as far as the endometrial receptivity is concerned. That does not
यश
mean
दरवाजा बंद
that
कर.
clomiphene is useless because
यश दरवाजा
please
बंद कर. लेक्चर चालू है.
hello that does not mean the only difference. There are two difference between uh, a couple of difference between letrozole and clomiphene. One, it has been observed that clomiphene reduces the uterine PI, sorry, resistance. It increases RI, uterine RI. So hypothetically, it is thought that the vascularity is hampered. This is only one study. The another, which is not there with the letrozole. On the contrary, letrozole increases the vascularity and facilitates the development of the endometrium. The endometrium is more thicker and better with the letrozole as compared to the clomiphene. When we compare clomiphene only and letrozole only, the another difference, the letrozole and clomiphene both increases the LIF gene expression, but the protein which is required for the correct action is done by letrozole only, not by the clomiphene. So here the letrozole scores above the clomiphene. So these are
Okay.
the three areas where the letrozole scores above the clomiphene. But when the clomiphene is used in the later half of the cycle, when the clomiphene is used along with the gonadotropin, the cycle outcome is not affected even if the endometrium is not comparable to letrozole. That is what I'm trying to tell.
Okay, sir. So this day 7 say when we add
Anybody,
clomiphene.
anybody else you want to ask something? You want to ask somebody? Want to ask something? Uh, chat. Let me go to chat. Okay. So, Dr. Momita, please describe again your natural and modified natural cycle for FET. That's another lecture. That's another lecture. Uh, you said in late follicular phase, when we give FSH, it will recruit more new follicle. So, do you say that in IUI cycle we need to stop giving gonadotropin after follicle crosses 14 millimeter? See, once the follicle reaches 15 millimeter, you can afford to stop gonadotropin or reduce the dose of gonadotropin, because once you stop gonadotropin, the follicle keep growing for next 4 days. The estradiol synthesis keep happening for next 48 hours. So once your follicle is 15 millimeter, suppose even if that continues for next 4 days, uh, at least it will become 19 millimeter, which is good enough for the trigger. So yes, you can afford to stop or reduce the dose of gonadotropin once the follicle reaches 15 millimeter. In IVF cycle, do we need to reduce the gonadotropin dose for example, the patient is on 225 international unit REC FSH, 150 unit HMG. Can I switch to 150 unit REC FSH and 225 HMG? In later last 2-3 days of the cycle, definitely you can do without any harm. Last 2 or 3 days of cycle before trigger, you can definitely reduce the dose of gonadotropin, which will cut your cost.
Thank you, sir.
Okay. Now, please, you're most welcome. Dr. Rekha, you are asking something, na?
Yes, sir. Yes, sir. Thank you,
Please
sir.
tell.
Sir, I was asking, like in IUI cycle, you had mentioned that once, like a poor patient, so if she can't afford HMG after letrozole, so after 10 millimeter follicle, even when you can just start low dose HCG.
I would advise you let it be
14,
somewhere around 11 millimeter, 11 to 12 millimeter.
12. So we can put it for 12.
Hmm. Yeah.
Okay. Yeah. Okay, so this is a new regime, and I think it'll benefit many patients, because with HMG, one injection costing 1300, 1400, they quite a time, many times they back out.
Mhm.
So, and
This
sir,
this protocol is not new. Some of the people, they keep marketing as if they have invented this protocol. This is Pilicuri. They have published long back.
okay, sir. But sir, you get it for us, because
Hmm.
we don't study so many
Yeah.
papers. Sir, and
Yeah.
one thing for IVF cycles, you had said that if you give CC in the latter part, you can do fresh transfer. So
Hmm.
that, sir, like if we start in poor responder, if we have started our low dose HCG with HMG also for the poor responder, we can add CC in on what day, sir?
See, sorry, my mind was diverted somewhere. Please repeat the question.
So in poor responder, like Poseidon 3, if we start with our luteal phase E2 antagonist HCG, then we come with on the stimulation phase, then when to add CC. Like we start with HMG, and with low dose HCG, she's a poor responder, and I
Hmm.
want to do transfer.
No, no. You want to add CC.
Yes,
So
in the
in
latter part.
luteal E2 antagonist protocol,
Yes, sir.
you give estradiol, then you give antagonist for 3 days, and then you give small dose of SCG.
Yes, sir.
This SCG can be continued during the stimulation. That is one thing.
Yes, sir.
Now, if you are continuing SCG in a smaller dose, I will not recommend to use the clomiphene again, because it will again increase the LH activity. And too much LH activity when the follicles are getting recruited is not good. So don't combine low dose SCG and clomiphene. If you want to use clomiphene, don't use SCG at the beginning of the cycle. That's my recommendation.
Got it, sir. So if
Yeah.
like we want to save our injection, the patient doesn't want too many pricks. So when we give E2 luteal antagonist protocol, we give that in the luteal cycle, previous cycle, and we start
Hmm.
a stimulation with only HMG. And then
Hmm.
with HMG, can we combine CC in the latter part?
Yeah, it can be. So
So, sir,
the couple of days I was describing somewhere the uh, mm, the letrozole protocol, stop agonist stop protocol with the letrozole. Do you remember? So
Antagonist
that
stop.
protocol I firstly use in one patient, and just now I did the pickup of that patient. Just now,
Okay.
before 30 minutes only, I did pickup. So
Oh,
that protocol is ideal for poor responder who are having short cycle where you suspect asymmetry. Still, you do not want to use full-fledged long agonist protocol, and you are facing difficulty in antagonist protocol because of the asymmetry. Then this
yes.
protocol is ideal protocol where you give OCP for 15 days or maybe, and then you start lupride, small dose of lupride, standard dose of lupride at daily dose, and you keep giving till patient gets the menses. Once the patient gets the menses, start letrozole for 5 days. Don't start gonadotropin. After 5 days of letrozole, start gonadotropin and treat that cycle as an antagonist protocol. And I give today dual trigger. In spite the lupride was given, and the as far as the follicle output rate, I'm quite happy. So let's see further. I will update about the oocyte quality and fertilization and other things. So this protocol I have used for the first time. So whenever I say this protocol is worth trying, I have always tried in my practice before I advocate to you all. So please uh, always assume that whatever I am suggesting, I have incorporated that thing somewhere, sometime back, or maybe currently I'm using them.
Okay, sir. Yes, sir. You always tell us that we have tried in a couple of patients.
Hmm.
So,
Hello,
okay.
sir.
Okay, Dr.
Hello, sir.
Sunita. Dr. Sunita. Okay, Doctor. Who was asked?
Hello, sir.
Doctor. Yeah, tell me.
Sir, in agonist, the stroke protocol, what you have said, we have to give trigger always lupride or HCG lupride mix, anything given according to follicle.
By default, always give dual trigger. When OHSS is not suspected, always give dual trigger. Never give only single trigger. When
Okay,
OHSS is suspected, don't give SCG trigger.
okay, sir. Thank you.
Hello, sir.
Yes, sir.
Yes,
Hello, sir.
yes, yes.
So, Dr. Sunita on this side.
You are not
Sir, I
audible.
just
You are
want to
not
ask.
audible. You are not audible.
Okay.
Please speak again.
Sir, I just want to ask why Letro's 2.5 is better than 5.
Oh, okay. So what has been observed that when you use letrozole 5 milligram by default in all patients, and you call the patient after finishing the letrozole, the follicle is recruited. By the time the patient comes to you on cycle day 8, the follicle reaches 14 millimeters. And if you look at the endometrium is barely 5.5 millimeters. So you are stuck. You are worried. The follicle is growing day by day, and the endometrium is not able to match. Now, this happens because of the anti-estrogenic activity or aromatase inhibition activity by letrozole. And this gets corrected soon once the follicle starts enough quantity of secretion of the estradiol. And this estradiol, as soon as it reaches to the endometrium, which is underprivileged, underdeveloped because of the aromatase inhibition, there is a hyperquintination. Quintination, that word I do not know what is the exact meaning. But for understanding, I say that it is deprived endometrium, craving endometrium for estrogen. And once the receptors are craving, they are crying for the estrogen because aromatase inhibition. And once this estrogen reaches there, suddenly the proliferation starts, and which takes care of the deficit or lagging behind of endometrium in next 3 4 days only. Next 3 days only. But in next 3 4 days, you should be able to prevent the LS surge. That's the biggest challenge because LS surge is not dependent on endometrium. The LS surge is dependent on the follicular readiness that signals are given from the oocyte to the pituitary. There is a little progesterone elevation, and which changes the rhythm of LH secretion from the pituitary, and that's how the LH surge is initiated. So, when you are using 5 milligram of letrozole, and the scenario where the letrozole, when endometrium is lagging behind, you have to be watchful uh, for a couple of more days for ovulation and LS surge before taking any decision of IUI or transfer, whatever.
Thank
Excuse
you,
me,
sir.
sir.
Good
Excuse
evening.
me. Can we
Yes.
give injection antagonist during these 3 days when the follicle is 14 and the endometrium is lagging behind? So to avoid premature surge, can we give injection Cetralix for 3 days?
Now, this
To
is very good question.
yeah.
Now, this question has been discussed in some other platform where the expert advise that you can use an antagonist. As per my understanding, so far so many studies I have read, the what information I have got is it is detrimental to use antagonist when there is no gonadotropin is added, because the
Okay.
antagonist substantially bring down the estradiol level because of the inhibition of the LH, rapid immediate LH inhibition. There is a fall in the estradiol level. So if they are not supported with the gonadotropin, so if you want to use antagonist, always add at least 75 unit of dose of HMG. Then you can afford to give antagonist.
Can we
Sorry,
give
sir.
estrogens? Can we give estrogens also along with the
Ye-
antagonist
Why?
to prepare the
Yes, why not?
endometrium?
Yes, why
Yes,
not? We can.
uh, we can give endometrium and HMG also. You
Yes,
recommend 75
yes,
HMG.
yes,
Okay, thank you.
Sir,
Sir,
so may I, sir?
some,
May I, sir? Sir,
yes.
actually, I have tried this ant in again in IUI cycle, sir. Even with HMG also, if 75 HMG also, the follicular growth rate suddenly drops. Then it does it mean to say that whenever I add ant, I have to add the HMG dose a little higher?
Yes, obviously, yes. So that is why, that is why I say that always cover it with the adequate dose of SCG. So 75 is bare minimum, but the BMI is high. Then you might have to increase the dose and make it 150 also.
Okay, sir. Okay, sir.
sir,
Thank you,
sir,
sir.
some people are giving the antagonist a half dose for preventing the LS surge. Is it okay, or we have to give full dose 0.25?
So suppose if you want to use half, there are, see, during various dose finding study,
Mm. Yes.
the LS surge incidence following half dose of antagonist versus the incidence of LS surge of following full dose of antagonist were not significantly high. It was high as compared to the
Okay.
250, but
Okay.
not significantly high. So
Right.
when you are thinking about the economy, when you think that something is better than nothing, then
Right.
you might give half dose of antagonist.
Okay.
In some of the study, somewhere it has been mentioned. It is not a common practice.
Okay.
So something, if you are using it like something is better than nothing, in that way
Right.
you can use half dose of antagonist. But you have to understand that if you are using in this way, you cannot preserve the reconstituted solution for next day. You have to use PFS, half PFS today and half
Oh,
PFS tomorrow.
okay. Thank you, sir.
Yeah.
Hello, sir.
Yes.
So just one question in this agonist stop protocol, which type of gonadotropin you used, and how long the stimulation was there? For how many days you did the stimulation before trigger?
Stimulation, I have to check. The file is not with me now. Okay. But it is standard stimulation. I think 10 days, 10, 11, 10 or 11 days. 10 days of gonadotropin or 11, maybe 11 days of gonadotropin. And
Sir, which
gonadotropin now, see, does not make any difference, I tell you. This question, I
5
think we
days
should,
letrozole.
please, uh, I'm muting all. So those who are asking only can unmute question. Okay. So I think we should now stop discussing that which HMG to be used. I give my final answer in belief. As far as choice of gonadotropin is concerned, FSH and HMG are treated same by the follicle. It is treated same in the same way by the follicle. The only difference, don't follicle does not think that okay, it is HMG, so it is better and it is providing significant LH activity. No, the LH level, serum LH level, following HMG, if you measure, and serum level LH level following FSH, you measure, there is no significant difference. Don't forget that HMG is providing too much LH activity. So when LH activity is needed, you have to give LH separately. So that solves half of the problem. Now, which HMG, which gonadotropin to be used? Urinary FSH, highly purified FSH, highly purified HMG, or recombinant FSH. All are same. Even in PCOS, they are same. Even in poor responder, they are same. In some poor responder like Poseidon 3 and 4, where extra LH activity is needed, you provide extra LH activity with recombinant FSH, it works well. My personal preference is always recombinant FSH for the simple reason that raw material which is used in HMG, it is supplied by only one country, China. And China is not a very reliable source where you can depend on their what you call quality and assurance. So if you have good HMG, good batch, I mean to say good batch of HMG, which provides you your desired result as follicular development as per your expectation. Now, what is your expectation? Your expectation is when you start gonadotropin in the right dose on stimulation day 6, at least 70% of your follicle, antral follicle, should reach more than 11 millimeter. If that is happening, don't change the brand. Use HMG only because that will save a lot of cost. But if that is not happening, that means the the HMG is not giving desired effect. So either you have to use the increased dose of gonadotropin next time for this batch than your standard dose, or you have to switch over to RFSH. The RFSH is genetically engineered product, biosimilar product, which is manufactured from cell line artificially. So it's a reliable source. The stability is better. It can withstand the change in the temperature in a better way. So as far as the desired response is concerned, RFSH is better. But fortunately, if you get a good batch of HMG, nothing like HMG, nothing like HMG. HMG for all, if you are getting good batch of HMG. But the problem with the Menopur is so costly, it's unaffordable, it's unaffordable. So they keep telling you that it's only gonadotropin which LH activity which is derived from SCG, which is not true. It is absolutely false. I have I have I had a very hot discussion with some of their foreign faculty who keep coming and keep promoting the menopause. So he was also answerless when I asked this question. So please don't think that the menopause is the only company which is providing LH activity which is derived from SCG. No, it's not true. I lost the track. Where was I? So HMG is, if you got reliable, HMG is best. Otherwise, try using RFSH. For all cases, may it be hyper responder, may it be poor responder.
So most of the HMGs have LH activity in the form of HCG only. So what is the difference? Some claim that we are giving it with like Minotas XP, they say that we are giving with HCG, the LH activity. Whereas other HMGs also, if you dig into it, the LH is not in the form of LH. That is a very costly thing. They give it in the form of HCG only.
Absolutely. That is what I was discussing. Yes. So what is your question? You're right. Absolutely right. Anupama, where are you?
So am I audible?
Yes, now you're audible.
So I'm saying that what is the difference between one type of HMG versus the other type of HMG? Everybody is carrying the LH by HCG activity. So is it the difference between the FSH element? What is the difference? But they claim
No,
that
no.
our
It's a difference. There is a difference in a purification process. Number one, and two, in the raw material. Gradation of the raw material, it's different, and the purification process is a different. So by purification process, some proteins which has got inhibitory action, they are eliminated if the purification process is the best. This is what I believe difference is. Nothing more than that. Rest everything is a marketing gimmicks.
So the thing which they are saying that HCG is added for LH activity, it is there in everything. So that is just a marketing gimmick.
Now, how many of you know that Senzyme, that is Senzyme, which is now marketed by JB Chemical, they come out with 1200 IU of lipolyzed gynogen. How many of you know? Do you know that?
So what's the difference? We don't know.
Yes, sir.
The difference between other gynogen, which is available 150 lipolyzed, this 1200 lipolyzed is also lipolyzed form. The difference between two is they claim that this is lipotech technology, which is different technology. And because of this technology, even after dilution, you can keep in the freeze, and you can use for 28 days. That is what they have given in writing. So this is something which is amazing. Amazing. If not for 28 days, even if it lasts for 5 days, that gives a proof of stability of the molecule.
Right. Thank you.
So I started using that now.
It's available with which name?
It is Gynogen 1200. Gynogen, I will show you the picture. Are you able to see?
Mm, yes, sir. Now we can see. Okay.
So it's a 1200 unit.
Right. And it is the same one with Nivian Pharma thing?
No, Nivian keep telling that it is same, but it's not same. This is their own product, their patent, and till now they have not given this product to anybody. Even
Which company, sir?
this is JB Chemical.
Okay.
So this is also in short supply. When I ask for suppose I order for 100 vials, then they give 20 vials now. Then after maybe 2 3 days, they will give again 20 vials or 30 vials, because this manufacturing they have started just now only. And I probably I may be the first among the first few users. So the moment their batch is ready, uh, they are facing scarcity because a lot of people they have adapted this molecule. I mean this preparation.
सर को तो फ्री सप्लाई देनी चाहिए उनको, इतने बड़े प्लेटफॉर्म पे सप्लाई करवाने वाले सर। गैनोजन वाले सुन रहे हो ना?
गैनोजन वाले को बोलना पड़ेगा, तो तुमको बोलूंगा कभी कल से ऑर्डर आना शुरू हो जाएगा, तुम मेरे को डिस्काउंट दो।
थैंक यू सर।
So this
Sir,
is
recording of this session.
We now because I have subscribed to the advanced Zoom, I have paid the subscription. So all our meetings are getting recorded and it is available on my channel from the next day.
Okay, sir. Thank you.
Thank you, sir. Thank you so much, sir.
Thank you. So any question left?
Sir, I have asked one question, two questions. If there is a FS receptor polymorphism sometimes, and sometimes we can see the LH receptor polymorphism. So if there is a FSH receptor polymorphism, then we should add LH. It's like that. Apo.
Yes, that
And
also works well. See, FSH receptor, I have never tested for any polymorphism study. Never tested any patient. If I am getting suboptimal response, I take it for granted that there must be some receptor polymorphism, and I need to increase the dose. It is all those are research-oriented things. The only
Yeah.
practical solution is increase the dose of HMG or add some LH activity.
no, sir. Sometimes suppose like if I PCO patient, very lean thin PCO patient, and if I'm using REC FSH, and sometimes after 4 5 days, 7 days, still follicles are not that much, growing, only just 12 13 mm. So if you add little bit LH activity, then they start growing. That means there is a
Absolutely.
FS receptor polymorphism.
No, I tell you. This study has been published by Dr. Abha Mazumdar.
Yes,
So
sir.
they say it is a FSH resistant PCOS where the
Okay.
basal LH level is not high. In such patient, if you add LH, it increases the follicular sensitivity towards, it helps in developing more FSH receptor.
Okay.
And there is a more androgenization which also increases the sensitivity of the follicle towards FSH. And then if you stimulate with HMG, then the stimulation follicle recruitment starts happening.
Sometimes,
Actually,
so sometimes in poor responders also, instead of HMG, sometimes REC FSH works well. Why it is so? In some patients.
Then maybe just the molecular efficacy difference. RFSH is more stable drug.
Okay.
sir, in case of IUI cycles, is a dual trigger fine? So will it not produce luteolysis even though we are giving HCG?
See, in IOS cycle, whether you use dual, even if you, as per the study, even if you use pure agonist trigger, then also there is no problem. cycle outcome is not different. Very marginal difference as per the study. So you can very well use even agonist trigger also as per the literature. In practice, whenever I have used agonist trigger in non-IVF cycle, I always give small dose of SCG after 72 hours of my agonist trigger.
Okay, sir.
So instead of that,
How much, sir?
you can give dual trigger. That's a good idea. There is no problem with the dual trigger. But whenever may it be dual trigger, may it be only SCG trigger, always incorporate small dose of SCG after 5 days of your first trigger, 5 to 6 days of first trigger.
How much, sir?
2000 is sufficient.
Every third day or 5 days, sir?
After trigger, 5 days after the first trigger,
Then, sir, repeat.
not to repeat. By the time implantation is over, then the embryo will start, if she conceived, then embryo starts secreting FSH, I'm sorry, SCG. So this protocol is very well adapted by Dr. Nagori and Dr. Sonal Panchal, and they are getting really excellent result in IUI.
Sir, regarding the start of progesterones in IUI cycles, when to start, after IUI or standardly 36 hours after trigger?
So
Because in IVF, we always have 1 day of progesterone extra to the number of days of embryos.
see, in SCG triggered cycle, the progesterone level for next 3 days of trigger is just sufficient, not needed, not needed. So I always start progesterone within 72 hours. So maybe just after, maybe you can say third day, after 48 hours on third day, after doing the IUI 1 day, after 1 day of IUI, I start progesterone. Because I do not want to bombard with progesterone. Progesterone is needed most when implantation is happening.
So my
Hello,
query is if I start it a little early, will it be in any way negative? Like on the day of IUI, if I start the progesterone, will it be in any way negative?
Theoretical, it might affect because already the progesterone level is quite high. But Dr. Gemu or somebody who conducted this study, the early start progesterone versus late start of progesterone, he found Dr. Genu, I think so. I forgot the name of that researcher, and he found that there is no difference. There is no difference. The altered window of implantation is myth, and actually that does not happen. But still, I am in favor of not to bombard with too much of progesterone, and still I follow the practice after SCG trigger. If the ovulation is confirmed, I never ever start progesterone early. At least I wait 48 hours after the ovulation.
Hello,
Okay,
sir.
sir.
Hello, sir.
Yeah. Yes.
Sir, in IUI cycle, if we observe the ovulation, at the same time, endometrium is not so progesterogenic. Only triple line is seen. There is no progesterogenic effect in sonography at the time of IUI. We confirm the ovulation and free fluid is there. But in endometrium, there is no effect of any type of progesterone. Then what to add?
Nothing. Why you are thinking so much into the depth of IUI cycle? IUI itself success rate is 10, 12%, 12%. IUI is just a middle step. See, very few people who claim and actually have to confirm the result, whether they are right or not. As per my understanding, as per the international studies, as per most of our experience, the IUI results are not more than 12%, 13%, whatever you do. So, consistently. So, if you do not get a progesterone effect on the day of IUI, anyway, all IUI cycles are going to be supplemented with the progesterone, and all the cycles where gonadotropin has been used are going to be supplemented with the progesterone. So you should not worry. Yeah, you may start progesterone early once you do the
On the day
IUI.
of
I,
IUI.
yes, yes.
Okay, sir. Okay, sir. Thank you, sir.
Sir,
Yeah.
in an antagonist cycle, maximum how many days we can give citrolix? In a
Once
fixed day
the, once
cycle or
once once once
flexible?
once the trigger criteria are achieved,
Okay,
you can still give 2 days more.
okay. 6 or 8 days we
And
can give, no problem.
yeah, once it's not 4 days or 6 days or 8 days. Once the
Okay,
trigger criteria are achieved, you
right.
may prolong the cycle 2 days more, not more than. It's not advisable to pull more than that.
Okay. Thank you.
Sir, what is the size of follicles you take it as for trigger? Either more of 3 follicles more than 18 or up to 18. Most of the follicles are in 18 to 22, sir.
Most of the follicles which are more than 17 and maximum 22. Majority of the follicles 17 to 22.
Okay, sir. If we have to postpone a single day in that 17 to 22, will it be fine, sir?
Yes.
Yeah, absolutely fine. Once the trigger criteria are achieved, you may, if it is long agonist cycle, you can comfortably postpone the trigger. But if it is antagonist cycle, it's not advisable to postpone more than 2 days. More and more studies are coming up. By postponing the trigger, you get better yield of oocytes, but that is not translated into increased live birth rate.
Okay, sir. So by the 2 days, that 22 millimeter will reach 26. Not a matter, sir.
No.
Okay, sir. Fine, sir. Thank you, sir.
Yeah.
Hello, sir. Please answer my question. I've written in the chat box.
Let me see. This is last question because 12:30 already.
Yeah. Just before you leave, just answer that. It's a simple question.
What is the question?
Regarding trigger, I want to ask regarding trigger.
Progesterone injection for how many days? So please tell us your criteria for dual trigger and how do you give. Criteria I said 17 to the majority of the follicle between 17 to 22 millimeter. If it is non-IVF cycle, then I consider a couple of factors which I have discussed before deciding on the trigger. And if it is a dual trigger, uh, ideally the SCG is needed not more than 2000. Precisely, if you want precise answer, 30 units per kg of the body weight. But practically, we do not have that inventory for 1200 units, 1000 units, 2000 units, 5000 units. So normally we give 5000 units of SCG along with the one ampule of either decapeptide or luprolide, and 5000 unit of SCG. But 1200 unit of SCG is just sufficient for average body weight, or maybe 2000, not more than that, as far as the dosage is concerned. And that is to be given. How do you give? This to be given subcutaneous simultaneously. Uh, so that is what you wanted to ask. Am I right? In poor responder only or normal
Yeah.
also? And if
Together, both the injections together.
together only, together means not in same series, but one on the left side and on the right side.
Yeah.
Yeah, and
And in all patients, normal and
default,
pure responder. All the
all,
patients
all,
that
all, 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 all,
irrespective of E2, how much E2 should be there, cutoff value for
irrespective.
E2,
Okay,
irrespective.
for SCG, you know, see if the number of the I don't go by E2. If the number of the follicles are more than 15, I'm not comfortable using SCG. So I use only agonist trigger, no
Okay.
dual trigger. If the follicles are more than 15, dominant follicles.
Okay, sir. Thank you. Thank you very much.
Okay, so we end this meeting and see you probably next
Thank you,
weekend
sir.
or next
Thanks so
Sunday.
much, sir. Thanks a lot,
Thank
sir.
you.
Thank
Thank
you,
you.
Thank you so
sir.
much, sir.
Thank you.
Thank you, sir.